Okay, so back on asthma, and we were on, I don't know what number slide this for you, but on page 7, and now talking about dry powder inhalers. So for these, you don't need a spacer, and you don't need that and eye-hand coordination. What's the spacer for, Marissa? For the
For the medication.
meter dose inhaler, what's the spacer for?
So you don't, so you get rid of the medication.
Right, so the medication makes a little cloud, you have a longer time to inhale it.
But isn't it also for like the glucocorticosteroids, so you don't get the thrush and stuff like that?
Yeah, but not the spacer, just so it makes a little cloud.
Oh,
So that for the thrush, you rinse out your mouth, the main thing. You could get it anyway, but yeah, no, that's nothing.
okay.
Good question. Could make that a choice, make it a wrong answer choice. Okay, and then yeah, so some of them for the dry powder inhalers, not being funny, but you know, it's important to keep the thing dry. You're not rinsing these out and everything. Like with the meter dose inhalers, occasionally if you take out they should be doing every day. I don't know that people do that, but for the meter dose inhalers, they should be taking a canister out every day, rinsing out the holder of it and drying it. So now oral medications, and we'll talk all about these more in depth, but short-term treatment and long-term control, but you do get adverse effects due to systemic absorption. And typically for asthma treatment, we're talking about oral glucocorticoids is the oral medication, probably. But there's some long-acting agents too. Then IV is gonna be the glucocorticoids, and then some sub-Q injections. So then, going back to good old 100, talking about sub-Q is gonna be what? How long's that needle for sub-Q? Make it easy yourself. Just gonna be less than
Less than an inch.
less than an inch long, and gauge is gonna be 25, 27, 29. Yeah. Angle's gonna be
90 or
90
45.
or 45, depending on the person. So then there's short acting and long acting. Short acting we're gonna use for severe bronchospasm, immediate relief. Longer acting are for maintenance. And the different classes here, we're gonna talk about, chiefly the first two, bronchodilators and anti-inflammatory agents. So here we go, bronchodilators with beta-2 adrenergic agonists. So most frequent used for bronchoconstriction, because what it's gonna do, activate the SNS, sympathetic nervous system, causing smooth muscle relaxation, bronchodilation. So here's how you remember this one. So I have beta-1 and 2 receptors throughout my body. Beta-1 receptors, when we talk about cardiac things, if it's beta, they primarily work on beta-1 receptors, it's your heart. Beta-2 receptors typically are your lungs. So easy enough. I have one heart, beta-1, 2 lungs, beta-2 are lungs and smooth muscle. That's how you can think of it. And again, short and long acting medications, but are, and then inhaled PO, parenteral, it's really gonna be more inhaled than PO. Systemic effects can occur, so say, before we even get to the slide, a beta-2 agonist, so it causes bronchodilation. I even fact checked this to make sure it was selective. Beta-2 agonist, and our chief medication is gonna be albuterol. It says it's selective, but I will tell you, it does have adverse effects to the cardiovascular system. So if it's a beta-2 agonist activating our adrenergic nervous system, then what adverse effects are gonna happen?
Tachycardia.
Yeah, tachycardia, tremulousness, nervousness. And yeah, all that's not optimal, but we have to be breathing, we have to get air in and out. Have to worry about the tachycardia a little later on. And yeah, chronic use can develop a tolerance. I think that's probably true, but guess what? People still are gonna get the albuterol first and often.
You said you can go to tolerance?
Mm-hmm.
In theory, but they still will get it. So, short-acting beta-2 agonists, and where in the heck is, oh, it doesn't say it on the next slide. But short-acting ones, acute bronchospasm, 2 to 6 hours. Usually they're as needed, but this is a rescue inhaler. But as needed, and sometimes the longer acting was their first scheduled dosing. So here it is, albuterol, the generic name, trade names, Provenal, Ventolin, and does all those things. Bronchospasms, facilitates mucus drainage, and inhibits the inflammatory chemicals from the mast cells. Because remember, what were our big three things with asthma? The pathophysiology. You get
The inflammatory response.
yeah, the inflammatory response causes edema.
Oh, yeah.
So first it's gonna be bronchoconstriction, edema, and
Spasms.
mucus production.
Oh.
Bronchoconstriction, edema, mucus production. Asthma. So this is helping out with all of this. So drug of choice to stop bronchospasm, and you can use it as a preventative for if somebody has, if exercise, if activity is a trigger. So you can do it pre-activity. So selectively binds the beta-2, bronchosmooth muscle to cause bronchodilation. So if it's helping out with bronchodilation, that means it's so circle one, agonist or antagonist.
It's an antagonist.
Agonist. If it's helping out, it's agonist. If it would be blocking it, then it'd be antagonist. Because we talk about different chronic medications, they're gonna be beta antagonists, beta blockers. And then, so we already set up, because you're so ultra smart, so Nora-wise is gonna be what? Always throw headache on there, who cares? The headache, and now feeling jittery, tremulousness. ENT can give you a little bit of throat irritation. But the biggies typically are tachycardia, can even be dysrhythmias. So like Dawn was saying, which was great about how in CHOP they don't get nebulized treatments anymore. For adults, we still give them nebulized treatments. And sometimes they can even have hour-long nebulized treatments. So if somebody's on a treatment that long, then they're on a cardiac monitor. So you can really see, make sure their heart rate's not going up too fast, see if they're having any dysrhythmias. So hypersensitivity albuterol. So hypersensitivity, depending on where you look, some people using that term that means an allergy to it. Some people are terming it that you get more dramatic adverse effects. So if the person said that I can't use albuterol, what are you gonna do? Not giving albuterol. Simple enough. Never known anybody to say that. So if they already have a tachyarrhythmia, that just means a fast, irregular rhythm. Tachy, fast, arrhythmia without rhythm. And then prolongation of the QT interval. So when did we hear about that last time?
The
with, not a little bit of MAO, but more so with the tricyclic antidepressants, or whatever. But people are gonna know they have that, hopefully know they have that history, you know. And then if they have coronary artery disease or hypertension, and why is that? Because we just said, if it's a beta-2 agonist, it's gonna increase the heart rate, but also cause vasoconstriction of our coronary arteries. So if I already have coronary heart disease or hypertension, I don't want anything causing vasoconstriction. So it's a precaution because, one more time, if I can't breathe, I have to fix that. And fix the other things later, just gotta wanna be, mindful of it. So interaction is somebody's on a beta blocker or a beta antagonist. So beta adrenergic antagonists are commonly used for hypertension, irregular heart rates. So it could, if somebody's already on a beta blocker, meaning they're taken orally, it could block the albuterol from working as well. But we're still gonna give it to them. Always our goofy MAOI inhibitor. So basically think of, anytime you see MAOI inhibitor, it's bad. It's bad, it's wrong answer, it's whatever. Like they interact with a lot of things. It's gonna cause, because it can cause the tachycardia. And products containing caffeine. So caffeine really is a bronchodilator. But what else is it? It causes tachycardia. So, and again, if somebody's had coffee, we're not gonna give them albuterol. Yes, we're still gonna give them albuterol. So just look out for the heart rate. And so these are other short-acting beta-2 agonists.
Should we know them?
You might, sometimes you still see Alupent, like patients being on Alupent. I've never really, and Xopenex is how about, can I put it this way? The first two, we're not gonna see on our teacher-made exams, but you could see those first two in clinical, like used in the clinical area. And
Okay.
terbutaline, we really rarely give that anymore because it really causes pretty dramatic tachycardia. So they still do give it. And actually, and interesting enough, they give terbutaline for premature labor too. I have to research why that is, but. So just, you'll see those more clinically.
Sorry.
Don't apologize, they wanna choke you. So long-acting beta-2 adrenergic agonists. So just a couple examples for you. Probably some Mitrol, some Cerebenzone here. See a lot, dry powder inhaler. So PO is just oral. Brovan, which I never even heard of, inhaled nebulizer. But most important is just, I'm not using a long-acting thing to treat an acute attack. What I'm gonna use for an acute attack, but albuterol, first one we said. So, and, so used if you need more than one agent to control their asthma. There is evidence of having some suicidality with these agents. So if somebody has a history of suicidal thoughts with using long-term beta-2 agonists, beta-2 long-acting ones. Here's a money slide. This is an important one. So we want to make sure that they're using the inhaler properly. And like I said, really the key to that, they're sitting up, high thalamus, they're taking a deep breath in, exhaling fully, then holding their breath once the medicine's in there. Really review on page 481. It's always gonna involve using the spacer too, just to, again, a spacer so they can inhale the medication for a longer time. So taken as an order not to exceed the prescribed dosage, because what would that mean? If I'm taking my inhaler more often, means what? Right, yeah, the asthma's getting worse and I need to go in and seek emergency treatment. I'd be, I moved from the yellow to red zone, so need to go in and get checked out. So if they're on any medications that are gonna interact with beta agonists, and what did we just say? Beta blockers, MAO inhibitors. Adverse effects gonna be, our main thing is really the tachycardia. So the tremulous, tremulous is really, they really do get upset over being so tremulous, being so shaky and feeling so nervous, but it's the tachycardia that we really are concerned about. And then, where it says long-acting beta agonists, ensure proper use, just knowing that I'm not grabbing that one for an acute attack. So, inspection-wise, what I'm looking at again, when I'm doing inspection of somebody's respiratory system, I'm looking at,
Labored.
yeah, so if they're labored or unlabored, if they have retractions, if they have nasal flaring, if they're, leaning over. It talks more about that tripod position when it talks about COPD, but I've seen plenty of people who have asthma and they're leaning over like this to breathe because they're having such trouble breathing.
And the retraction, it's just like the use of the accessory muscles?
Yes. Yeah. Accessory muscle use, retractions, synonyms.
What is PEFR?
Oh, hold on, let's go through one at a
sorry.
time here. So vital signs before, during, and after administration, because I want to really check what? Blood pressure and heart rate, of course, what else? Pulse ox, respiratory rate, the whole thing. Breath sounds, so I should be hearing what? Hopefully, if they don't have a lot of wheezing, after breathing treatment, really it'd be better if I heard more wheezing. Like, I want the wheezing to go away, but if I don't hear any wheezing initially, remember that's really bad. If I don't hear any air movement, that means no air is getting in or out. So if I don't hear any breath, if I hear silent breath sounds initially, I want to hear them. If they already are wheezing to beat the band, I want the wheezing to start to improve. What do you but where am I how is the best to document these breath sounds? Anterior or posterior, are they inspiratory or expiratory? Like that all goes on what you're documenting. And then PEFR, remember, so how about, somebody can say it. Floral, remember that one from Tuesday? The PEFR?
What it stands for?
Yeah. You can look back.
Yeah, I remember it's a peak flow meter, but I don't remember exactly what it is.
Yeah, right, no, it's with that peak flow.
Peak expiratory flow rate.
Oh,
And with the peak flow meter, so remember how we have them do that? They're sitting up, they're not having gum in their mouth. You're focusing in. Inhale and you blow out fast as hard as you can in 1 second. So, respiratory, if you're in a place where respiratory therapist is doing, and the respiratory therapist is doing, whether there's inhalers, you do a nebulizer, they're doing it, they're gonna do assessment, but you're gonna do one too. You don't feel like you can't do the assessment too. So, then it's limit caffeine intake, again, just because you don't want them getting so tachycardic. Some people could say, drink the caffeine because it's a bronchodilator, but. So after any inhaler nebulizer use, really they should rinse out their mouth with water. And you don't wanna swallow the drug because why? You don't want, what's gonna happen if I swallow it? Well, yeah, most basic is it's gonna irritate my throat more, but otherwise I could have systemic absorption. You know, you don't wanna absorb more of the medication. And then palpitations, shortness of breath that's not relieved by the drug. So next class, anticholinergic. So anticholinergics, so they block the parasympathetic nervous system to let the sympathetic nervous system work better. So you can think, these are really to relax the smooth muscle. So, and I don't know why I did write this, but really important, generally you want them to do the bronchodilator first, you do the beta-2 adrenergic agonist before the anticholinergic agent. Because I want to bronchodilate first and then have the anticholinergic agent keep the bronchioles relaxed.
And you have to wait a certain amount of minutes in between.
Per your book, yes. Real life. So yeah, so commonly to give them with beta-2 agonists, because I want that additive effect, I want the two medications working together. And you have short and long acting, so short typically is ipratropium and long acting tiotropium. Spiriva. So here we go. Atrovent, so Atrovent, drug of choice for COPD, and COPD means chronic bronchitis and emphysema, which we're getting to just in a couple minutes. And I know, so per your book or ATI, whoever, says it's off-label use for asthma, so it's not. We give people with asthma ipratropium all the time. But, and then recommended as an alternative for short-acting beta agonists in severe exacerbations. And that's what it says on the slide. That's what to know test question-wise. Real life, we commonly give them together. Somebody's having acute asthma flare. And then this last one is is true, though. Typically, you're not given ipratropium for exercise-induced asthma. You're really just going to do the albuterol.
So this is another short-acting one along with albuterol?
Right, but it's a different class.
Okay.
It's a different mechanism of action. And so blocks cholinergic receptors to keep the muscle relaxed. Still gonna start to work in a couple minutes. So peak effect 1 to 2 hours, lasts up to 6 hours. You don't have to memorize those two numbers, just know it's shorter acting. So adverse effects, the same thing, can be some throat irritation, odd taste in your mouth. Respiratory wise, really nothing, can cause some cough. And GI, the usual nausea, some mild GI upset. But all those take precedence over breathing well. What a cute job.
See, respiratory is just some cough.
Yeah, some, Importantly though, because of the class of it, because it's an anticholinergic, it can worsen glaucoma. So glaucoma is what? Is increased intraocular pressure. I know we didn't get to it yet, but sorry, there it is. Yep. There's two types, so don't have to worry about it right now. The closed angle glaucoma is really the more common. What those questions are about. So, but that's really important. See if somebody has a history of glaucoma. So, test question wise, if you see this ATI, NCLEX about this hypersensitivity or allergy to soy, go with it. It's not true. It's not been true for over 20 years.
But that's what we're gonna see on the test, is soy.
If you see it, pick it.
Okay, I just wanna make sure.
Pick that. I'm not putting it on our test, our classroom aid test, because it's outdated. But so are MAO inhibitors, But I just want you to know, it's really safe now, like this, the additive soy lecithin. And then apparently reading this little article, there wasn't really conclusive evidence that that was even the causative agent, but.
Cause it says it in ATI.
Yeah, I know.
Yeah.
ATI isn't a nurse. Or some old, it's a nurse older than me, if that's possible. But again, if you see NCLEX or ATI wise, pick it, but it's no longer choose, Okay, so, no talking, people can hear. So, like Gary said, gonna be caused if somebody has a history of closed angle glaucoma. And just, and you don't have glaucoma yet, but I'm telling you, glaucoma is increased intraocular pressure. The closed angle is the more chronic form. And this being anticholinergic makes your pupil dilate. So if you dilate the pupil, it's gonna increase intraocular pressure. So that's why you should do. Then for urinary retention, prostatic hyperplasia, and bladder neck obstruction. So again, if it's anticholinergic, anticholinergic is the same as, yeah, anticholinergic. Remember we went over those when we talked about all the psychiatric medications. So it's gonna be what? Dry mouth, blurred vision, urinary retention. So I don't wanna give somebody who already has a history, a problem with urinary retention, prostatic hyperplasia. So hyperplasia means what? Enlarged.
Prostate.
Yeah, enlarged. Well, hyperplasia itself is enlarged tissue. So the prostate's bigger, gonna cut off the urethra more, and then it had bladder neck obstruction. What will we do? Say they really need this Atrovent. I'm gonna do what? Yeah, I'm gonna give it to them because they can't breathe, but I'm going to, well, before I cath them, good answer, but before I cath them, I'm going to make sure they're still urinating okay, palpate their bladder, get them to stand up, all that.
Bladder scan.
Bladder scanning, all that jazz. Yeah, so, and then, yeah, there's, I forget, I don't know whether it's in your, I'm mixing these up now, I don't know whether it's in your book or in the farm book, it talks about chlorofluorocarbons. They're not used for metered dose inhalers anymore either, and they have not been for a long time. It's an environmental concern. So, long-acting anticholinergic is tiopropium. Again, long-acting means I'm not using it for acute bronchospasm. What I use for acute bronchospasm, use albuterol and ipratropium. So once a day, dry powder inhaler. So here we go. So I want to know what their respiratory history is. Again, want to know if they have history of glaucoma or urinary retention. Because what I'm gonna say. If your vision gets worse, it's kind of silly though, but because that's the problem with glaucoma. People don't know they always have visual changes. But if I'm having trouble urinating, okay. So this would be for everybody. You shouldn't be sharing your prescriptions with other people. So again, at least weekly, though I think even daily is better. You're gonna take the canister out of the metered dose inhaler, rinse out the holder, allow it to dry. So you're not getting bacteria or mold to build up in there. And they should be rinsing their mouth afterward to prevent
Yeast, thrush.
to prevent thrush and again to prevent like systemic absorption. Those two. Thrush truly is more of an issue when we talk about the corticosteroid inhalers, but it doesn't hurt. Just think, Gonna tell them to rinse out their mouth with water after using an inhaler. Covers multiple bases. Here's telling you, yeah, 1 or 2 between the puffs of the inhaler, any new problems worsening, and like we already said, rinse and spit. So, it pains me to talk about these, and I have to go back to myself, I'm sorry. So we have to have a quick biological break. I drank